the denting ataupun direction of the pulp that we want. So the tertiary denting, if other than that, the term that you use, reparative denting or fractionary denting. The tertiary denting, if other than that, the term that you use, reparative denting or fractionary denting. The tertiary denting is the imagine that the term that you use has sign and symptom. Okay, this is kind of guideline for us. Okay, how we're gonna look into that case, every single case. So definitely, most importantly, you must get the thorough or detail of pain history, because it will bring you about what will be the pulp status prior to your clinical examinations or other investigation. So from the pain history, okay, if the tooth is asymptomatic, elicited or only have have a provoked pain, then we give you an idea it could be reversible papillitis. But if a patient have history of spontaneous pain, disturbed sleep, disturbed routine activity, then it will suggest the potential of reversible papillitis. Okay, then after all the clinical examination, radiograph, then you have to make some sensibility test is a must. Okay, it's a part of how we diagnose the pulpal status. Okay, so if the pulpal sensibility test give a positive result, so you will see. Okay, we see on the left arm first. If positive, okay, you have to see you see whether the pain stop or not. If the pain is stopped, then you can what you can offer to patient is either indirect pulp treatment, or basically vital pulp treatment that you can offer to patients. Okay, but if there is lingering pain, okay, even after removal of the stimulus, the patient still have a pain, then it could suggest reversible status of the pulp. But last time, traditionally, okay, the treatment is either you have to do you have to extirpate the pulp. Okay, but now even they have lingering pain or suggest reversible papillitis, we still can you can still offer conservative approach to the immature teeth rather than to extirpate everything. Okay, so then if a negative, then normally it will suggest pulp necrosis. Then as usual, the treatment that you can offer is a pulpectomy, efficacification or pulp regeneration. Okay, but in this for today's discussion, I'm not going to touch on the non-vital approach. My approach is going to be more to vital pulp therapy in immature permanent teeth, because it's quite promising result if you can really diagnose the pulp properly and do all the investigation that which I will discuss later. Right. So what influence our treatment options? Okay, this is I'm talking about the vital pulp treatment. Okay, first, definitely you really have to ensure the proper diagnosis. You have to be not to say accurately, at least appropriately diagnosed, either is reversible or irreversible. Because if we not correctly ataupun appropriately diagnosed, you patient may come back to you. You offer something like direct pulp treatment and all, patient might come back to you a few days later or tomorrow that you complain they have intense pain as compared prior to they come and see you. Okay, right. So actually, the other things that we might forget is whenever you want to offer vital pulp treatment or any endodontic treatment, you have to make sure that the tooth or the patient have a healthy periodontal tissue, because root canal treatment it's not about the treatment that you do or how good your endo treatment that you did, but the bacteria also can, the entry also can be from the gum. Okay, so that's very, very important is if you, your endodontic treatment doesn't end after you put your permanent restoration. Always you have to emphasize for the, especially our group of patients that they, some of them might not have a capable to maintain a very good oral hygiene, okay, even though they are 9 or 10 years old. So this one really they have to pay attention. Okay, fundamental thing must have good coronal seal because no matter how good, even your RCT in a permanent teeth, if you have a leakage, you might have a failure as well. So and then the control of hemorrhage, okay, the hemostasis that you get, and also what type of medications ataupun dressing material that you put on the as a placating is play an important role as well. So we're gonna go one by one for that factor. Okay, pulpal diagnosis. Okay, the first thing that you have to do, probe, dig, get detail of the pain. Okay, as I mentioned earlier on, and thorough clinical examinations. Okay, look at where is the complaint tooth. Look if there is a presence of reddish gum, swelling, Bakar sinus. Do a percussion, but do gently because if the tooth is really in pain when you percuss uh, in very hard percuss on that, you might trigger of sometime in a patient with uncooperative patients, you can get a disruptive behavior as well. Okay. Then when the time clinical examination also, you really have to see the adjacent. Sometimes it could be confused as well ataupun the contralateral teeth because sometimes when they get caries on other teeth, especially on the same side, it might show you to the complaint tooth, which is sometimes it could be confused. So look thoroughly for the apa nama clinical examination. Sensibility test, I will touch it later, and also good quality of radiograph. Okay, this is sometimes difficult for our patients. Okay, one sometimes they might have a gag reflex, or when we try to push further in, especially for the post-mandibular teeth, they might feel uncomfortable and refuse. Okay, so good quality radiograph is a must, is a baseline record because you're going to follow up the patient. So you can't just leave a patient after you are done your endo treatment. So you want to see if there is a complications. Okay, that is going to be baseline. When we talk about good quality radiograph, we need the radiograph that you can see up to the periapical area. So we have to see the periapical tissue bifurcation area to make sure that okay, this tooth is still vital prior we do any kind of vital treatment. Okay. For the radiograph, okay, for immature permanent teeth or inoperable effective, sometimes we might be confused. Okay, if you see the photos on the right side, oh sorry, on the left side, you see, you can see a presence of periapical lesions, but it's not only on the periapical area, it also involves at the lamina dura, the increase or radiolucency at the lamina dura area. So it will shows that there is the inflammation or infection on that area. But if you see on the right area, you see the periapical area, it looks like periapical lesion, which is not. Okay, in upper effective or the apical papilla might see radiolucent in radiograph. So whenever you see the case, please see thoroughly and don't be confused. Okay, we might apa nama do some the treatment um, more than as compared to needed. Okay. Okay, this is the issue with sensibility test. It's not kind of issue. The things are, that we have to bear in mind, and which is a thermal. Normally we do for thermal we do cold test, and EPT have limited reliability in young permanent teeth. Okay, one, if we want to see a factual factors, sometimes they can't appreciate that the when we do a sensibility test. Okay, and the other thing is sensibility test. It will not definitely tell us the extension of the inflammation, how deep the bacteria has goes in. So, and also Johnson and all say that it is the reliability, the EPT is not reliable to determine tooth vitality till the tooth innovation is completed. Okay, that's why one of the reason in open teeth we can't get uh, the, the, the result that we want it in unreliable. And the other option that we have, a cold test, okay, is been found that is more reliable for the a young permanent tooth. But if you get negative cold test, it shows that the tooth could be non-vital. Okay. All right. Again, in our patients, sometimes it's very difficult for us to get good history of their pain, and also uh, sensibility test might not give you the correct answer that you want. So we left to one option, which is we call it as operative diagnosis, which is we have to enter the tooth. We have to open the tooth to do a direct evaluation of the bleeding or the pulpal tissue. Okay, so this is definitely you have to. You have to do under LA and also good isolation control. So we're gonna do a caries free, remove the infected, remove the pulp until you can get the healthy pulp tissue. How are you going to determine this is healthy pulp tissue? The indicator is if you see after you remove the infected tissue, you see you can get red color of the bleeding, okay, and you can achieve the hemostasis with a less 5 minutes. So that then you can offer vital pulp treatment to patients, okay, right? But if you keep on cut on the pulp tissue, that then you can't get the hemostasis, or you see the color is a deep purple, and normally we're not so happy with that color, and then it shows that the tooth could be towards to become non-vital. So when it comes to this, so definitely the option that we have is non-vital pulp treatment by means of either pulpectomy or regenerative endodontic, or incomplete root formation, complete root formation, that you can offer the conventional root canal treatment. Okay, this is the tooth that if you see there is a pulp exposure while doing the caries free, okay, then partial pulpotomy was done, then we see the tooth still survive. Okay. All right. Wherever we talk about vital pulp treatment, the option either you want to do a indirect or direct pulp treatment, or partial pulpotomy, either partial pulpotomy or cervical pulpotomy, or we call it full pulpotomy. The other than the good the tooth is can be restored. The other things indicator is the main factor is pulp capping materials. Okay, we must have the materials that can prevent from the re-entry of the bacteria. Okay. In the same time, it must be biocompatible, it's not resolvable, and also it must be capable to establish and maintain a good seal of prevent bacterial contaminations. And the other thing, it must promote the repair. Okay, so in literatures, okay, the the gold standard that we see is as calcium hydroxide. The previous, I mean, the standard material that used is calcium hydroxide, and now because of the advancement of materials, okay, and it's in MTA, is comparable. The success rate is comparable. Okay, then why calcium hydroxide become a gold standard? Okay, because it's have alkaline pH, okay, which contribute to the antibacterial activities. Okay? And also it can ability to induce reparative dentinal breach, which is what we want. Okay, and also by stimulate the release of active dentin metric proteins. However, calcium hydroxide have drawbacks. Okay, they have the dentinal breach that formed by the calcium hydroxide. They have a tunnel defects and also porous. Okay, and also because it's soluble, then they have this. You have this. This there is a dissolution over time. So we come to that. Just imagine if our patient that we do buttercup treatment at the age of 10, so the tooth should be there. We never we never know how long is the patient can be. So definitely it will have an impact on the prognosis for the tooth. And also the disadvantage is inability to provide long-term seal against micro leakage, okay, which definitely will have an effect on the prognosis. On the other hand, for MTA, they have similar property, okay, a comparable property as for calcium hydroxide, but the advantage as compared to calcium hydroxide, it produces thicker dentinal bridge in a shorter time, okay, and with the minimal tunnel effect, okay. So it also decrease um, of the necrotic area. It's just that this advantage is discoloration, the major drawback of MTA. Okay, so it is advisable not to use MTA at the aesthetic area, which means wherever you get a case of permanent anterior teeth, please you can use with the calcium hydroxide or biodentin. Okay, another thing is longer setting time, but for the longer setting time, I think depending on the supplier or the brand of the product or MTA, now they are some of the brand they offer shorter setting time. All right, so whenever you have the tools with the, you are confident that the tools is the reversible, in the tools have a, the diagnosis is reversible papillitis, what you can offer to patient is a direct capping technique. Okay, here I'm not going to discuss about indirect pulp technique. Okay, because in the indirect pulp technique, I think there is a two different type that you can use stepwise and also a single visit. But for this discussion, I'm not going to touch on that. So for the direct pulp capping, any vital pulp treatment rather than isolation is a must, because if you don't do this, you will compromise the prognosis of the tooth. Okay, so when you go to the cavity preparations, okay, you can use high speed burr, but when the caries removal, as usual, you use speed burrs. Okay, copious irrigation with a sodium hypochlorite solution. Okay, this is the purpose is to disinfect the cavity. Okay, because you want to get the area clean, especially on the pulp area. Okay, so and the other function of the sodium hypochlorite is to remove the blood clot from the pulp exposure site. Okay, this is the reason why is that when you don't you have to remove the blood clot prior of the placement of your pulp capping material. Okay, because these blood clot may result in dystrophic calcification. We have a risk of internal resorptions, and also they will interfere with dentinal bridge formation. Okay, so really have to make sure that you can clean blood clot because your capping material should be on the pulp tissue. Okay, after you get the hemostasis, you get the hemostasis or can control the bleeding, then you can place your dressing materials by means of MTA or calcium hydroxide or biodentin. Okay, the ideal thickness is with 1.5 to 2 mm, and straight away on the same visit, please make sure that you be able to put your permanent restoration. Okay, because if you delay it, again, it will compromise your prognosis of the tooth. Okay, right. So when we talk about the pulpotomy, okay, so I'm sure that all of you know what is a pulpotomy. It's not something new, but when we want to manage the caries exposed immature teeth, then last time there is no pulpotomy anymore. So now we still have an option. Whenever you treat or you want to manage immature permanent teeth, please be conservative. Okay, not everything you have to accept it apart. Give a second chance to the tooth because you really need the root completion. Okay, after the root completion, then you still, I mean, you still have root canal, which is you can do. But when it's open apex, it's going to be heavier for us also to manage. So in the pulpotomy, the concept is the depth of the tissue removal based on the clinical judgment. Okay, the clinical judgment here means the bleeding behavior, the bleeding status. Now, earlier on, I mentioned about the color of the bleeding and also the bleeding control. Only tissue with profuse bleeding that could be inflamed or infected should be removed. You will leave behind the healthy pulp tissue. Okay, so then you same like DPT. After you remove the infected pulp tissue, you're gonna put the pulp capping materials. Okay, in pulpotomy, we have two type of pulpotomy, vital pulpotomy here, which is you have partial pulpotomy, or if, for example, when you try to remove the pulpal tissue and it end up, you have to remove more. Sometimes you have to remove the entire coronal pulp tissue and leave behind the radicular pulp. Okay, partial pulpotomy and cervical pulpotomy provide a more predictable outcome as compared to BPT with caries exposure tooth. Okay, this is a systematic review done in 2015, if I'm not mistaken. You see the treatment outcome of the DPT in the permanent teeth. In here, they don't mention about is open apex or closed apex, but if you see within 5 years, okay, we have a good outcome, but towards, I mean, the longer that you follow up the patient, then you see the success rate is reduced, okay, but this result we have to read it careful because sometimes when become more years of review, the patient might not turn up to you, make the success rate percentage is reduced. Okay. But most of the cases here, the follow up is up to 1 or 2 years, okay, which give a good success rate. But when we see on the partial pulpotomy, most of the cases, the researchers, paper, they follow up a patient more than 3 years, and you see the success rate is higher as compared to the BPT. But again, this one we have to read it carefully because a few factors like how they remove the caries, is it the method of their caries removal, open effect, closed effect doesn't mention. Okay, but basically generally we see it's a good outcome of the treatment. This this one also goes to pulpotomy, meaning the cervical or full pulpotomy. It gives you almost 100% success rate, but the number of the piece that follow up is a very small. Right. The most important thing that when we do vital pulp treatment, okay, don't just leave a patient. After that, you must closely follow up to the patients. Yeah. So, like any other treatment that you do, always we have to see clinical assessment. Okay, we have to mention you have to make sure that if a patient have any uh, sign and symptom. Okay. The other thing, please, sometimes we might say, oh, the patient come to you with a symptom of pain, or you see there is a swelling and all. You might think, oh, this is a failure of the PAP treatment, which is you have to be careful in terms of you see first, is really the vital PAP treatment that failed, or the restoration, the current seal that defective. Sometimes it's not the treatment, the vital part treatment that fail, but it's because the final restoration might have a leakage. Okay, that's why wherever that we do a final restoration, if I need a full coverage, standard stick crown might be an option, but sometimes we don't have that. But don't put like GIC. Please do something that composite resin that give a better prognosis. Okay. This is we have to coronal seal or permanent restoration, like we have to really pay attention because we already done the good job to save the tooth, but it's just that the fail because the material that we choose or the patient or the hygiene is not good. Okay, again, the other entry of the bacteria could be from the gum. So this factor we have to emphasize on patient. Oral hygiene, we really have to reinforce, we really have to give a reinforcement to that. Okay, and radiographic assessment. Okay, so it's not that there is no guideline to say that, oh, you have like trauma, dental trauma, you have, okay, 1 month, 3 months, but it's not, there is no kind of fix. When are we going to do a follow up? Okay, it will based on the clinical presentation as well. Okay, so you can see your patient 3 months, and if there is no sign and symptom, it could be 6 months. But this is the things that you should look into. See if there is a periapical lesions, root resorptions. Okay, there is a case report showing that there is presence of root resorption following by treatment. And the most important thing why we do a vital part treatment to immature, definitely we want to see the evidence of the root development. Okay. So again, I have to emphasize on this one. Factors influence your treatment outcome. Okay. First is always go back to your diagnosis. Okay. If you get the correct diagnosis, inshallah, the treatment, patient will be okay. Okay. Then isolations is a must. Okay. Yes, sometimes you get a patient that it's a bit difficult. Okay. That's why we have to really to inform the parents. okay, that the longevity of the treatment might be compromised, okay, then coronal leakage, okay, it always goes back to your coronal seal. And also the other thing is caries removal. You have to make sure that you do a proper caries removal. Thank you. I think this is the last slide. Okay. Follow up after the vital part treatment, or what is the complication or consequences that the patient might have following the vital part treatment. One of the things that we really don't want is a part necrosis, but it's not impossible if one of the factor or there is a factor that's compromised. Pulp canal obturations. Pulp canal obturation is not to say that the pulp is non-vital, but when it comes to this, you as well, we have to. For me, I always consult the endodontist. Endodontist is the right person. If anything that in doubt when it comes to endodontic, because either they want to intervene, okay, when they intervene with the with the root canal, or just with it as it is, okay, and also the root resorptions. Okay. I think that is the end of my presentations.
Okay, thank you, Shikin. Let's see, maybe if anyone would like to pose a question, could you please put it in the chat box? So maybe while waiting for the questions, so now, Shikin, that means we are embarking on more and more on vital pulpotomies for molars, right? You're talking about molars. And so in your experience, you're receiving more, like, is it due to MIH? Is it caries? Or because I would think that there's a difference between a caries molar versus an exposure that occurs because of MIH. Because the structure of the dentin, people tend to remove a lot of dentin in MIH because it's slightly soft. So then you get this kind of exposure. So any differences in that? Would you?
Okay, but first of all, if you see in terms of caries, purely caries, permanent tools or in MIH, and the other how to manage in purely caries, then normally we don't have the problem after we give LA then we can manage to get the numb and we can do a good job on that. But this one is a bit difficult in the MIH patient, because even though you get the high, sometimes after a patient because with PEB, it's more difficult to get isolation. LA sometimes not really work, and patients still have hypersensitivity or pain. So that one is gonna be they have a different kind of approach for the MIH. But what I'm discussing is purely the caries exposure. Caries exposure that normally is seen is one is misdiagnosed. Okay. Second is, like I said, defective restoration. Because sometimes when we see, oh, there is a restoration, we not really look into that. Okay. So actually, whenever you encounter large restoration, like the IC or amalgam, please look at it, investigate the tools, because there is a possible chance of becoming non-vital or infected. But in a MIH, the approach could be a bit different, okay, because of the other factors that I mentioned. Normally, the other option for PAP therapy, we call it, is an interim therapeutic restoration, which is we try to remove as much of infected dentin, okay, and then infected dentin. We put the medicaments and then we put a semi-permanent. We'll see how the tooth reaction. and then we see, do call the patient within 1 or 3 months, see if there is a sign and symptom or not. If tools are free of symptoms, then you can offer a patient with a more definitive, like stainless steel crown. Because as you said, because the dentist is so soft, we tend to dig and dig and dig until like the caries exposed, the caries teeth, which is it will cause more problem to patients. Sometimes we just remove as much as possible infected dentin, put your pulp capping material, advisable, uh, if you can put like MTL, biodentin, and put your semi-permanent or permanent restorations.
We've got some questions coming in. So the first question is from Jeannie, who asks, can disinfection of exposed pulp be done with chlorhexidine?
Okay, right. I have no paper to say that, but you can try. Okay, you can try because at the end of the day, what matter is your pulp capping materials and coronal seal. Okay, you can also sometimes I do use a saline. Okay, because like I say, in our patient, we try to do ideal technique, rubber dam and everything, but there is some patient that you can't. But in the same time, you have to put all the effort to save the tooth. Then when the rubber dam, you try with the cotton rod isolation, then definitely you can't use sodium hypochlorite. So saline or I don't think chlorhexidine will be something that will be the problem. Yeah, I think you can use.
Given a choice, perhaps would you say saline in a vital pulp, perhaps?
I would prefer. Saline would be the options.
Okay. Second question from Xiaoping. So how do you know and how do you decide whether it's a partial or coronal pulpotomy on permanent teeth with caries exposure?
Okay. Definitely one is the bleeding behavior, the color. If you consciously remove the infected pulp tissue. Okay, if you can get or you can stop the bleeding, okay, then you have to stop there. Okay, but when you try to remove, you still can't get hemostasis, then it shows that you have to go a bit deeper. Okay, but sometimes when you remove so much, then it eventually become coronal pulpotomy. And second thing is that I see when you do a sensibility test, okay, there is a lingering pain. Okay, it shows that it gives an idea that the tooth might become might have a irreversible pulpitis. Then then at in this kind of I always go to cervical pulpotomy or full coronal pulpotomy because it already shows the sign of irreversible pulpitis.
Okay, we have a question from Dr. Sumadi. If pulpal obliteration is an indication of vital pulp following pulpotomy, do we still have to consider RCT?
It will depends. It will depend because obliteration is not a sign of a non-vital. Okay, but the problem is, for example, that will become non-vital in future. So definitely will be headache for the for us or for the endodontist to do the root canal treatment. That's why I said when you have see evidence of pulp obliteration, especially in initial stage, normally I will advise to consult the endodontist because if they want to do a prophylactic endodontic in view of the future problem for RCP. Okay, I have no definite say. You have to start with root canal treatment, or you can just leave it. Okay, because again, it doesn't show. It doesn't say that it's a non-vital. It's still vital because reactive of the pulp tissue make it obliterated. Okay, because sometimes the tooth is okay there, so why you want to disturb? Okay.
Next, I'm sure this is not the name of the head doctor, November. Okay. So he or she has a 3-year-old patient with periapical abscess on A1 due to caries. So would you do pulpectomy for this patient? And if this patient is uncooperative, is it possible for the abscess to drain by itself?
Okay, when we look into the endodontic point of view, wherever have infections, okay, the first thing that we must do is to remove the source of infections. Okay, either for 3 years old, because sometimes 3 years old sometimes aesthetic might concern, and parents doesn't want. Okay, first of all, you have to see the overall dentitions. Okay, so and the remaining tooth structure that. Okay, if you think that the tooth can be restored, yes, you can do a pulpectomy and then followed by the strip crown. Okay, you offer aesthetic things, but if you see the general dentition patient has severe ECC, so I don't think to save the tooth will be a good options. Okay, so and then the other thing, uncooperative patient, it will depends. Okay, yeah. If you have an opportunity ataupun you are plan the patient to bring the patient for under GA, and then also the only one, the front is only one foot that affected, the rest just small restoration we want to do under GA, then it could be okay. But normally when we come to under GA, I of this is me, I always goes to the extreme part. I'm gonna extract the tooth. But another thing, if you think that you can still manage the case, it's no harm for you to try. But to extirpate the pulp and then put your permanent restoration. But again, the fundamental is good coronal seal. It's no point that you remove the tooth. I mean, you do a pulpectomy. I mean, patient a struggle. At the end of the day, the restoration keep on dislodge because the end result is extractions. Okay.
I guess you also said that self-drainage is not really an option.
No, because if you give medication or something, that it will disappear, but eventually it will come back. So definitely you have to do something, either pulpectomy or extractions.
We've got lots of questions for you. She can get all right. Do you think DPT on permanent molar is equally successful in deciduous teeth? That means the DPT on permanent and deciduous is it equally successful?
To say that, whenever we see the behavior of proper behavior, primary dentition, primary teeth, immature teeth, permanent teeth is different. Okay, when it comes to the primary teeth, it's not advisable. Okay, you still can have, if a patient have asymptomatic tooth, but you say you can do indirect technique. But whenever it comes to very near to the palm, okay, or mechanically exposed by you do a caries keys, I think pulpotomy will be the best option rather than the direct pulp treatment, because definitely this is something that it's not the same. Okay, but primary and permanent is the approach a bit different when it comes to the direct pulp treatment.
I'm asking, how many days will you review the patient after vital top therapy?
Oh, okay. So normally I don't call the patient too soon. Okay, I will leave it a patient that remind. Okay, because and then because there is no guidelines, Okay, if you think that okay, I'm a bit worried this patient, not although you are already know, okay, you have the diagnosis, you do whatever that need to be done prior to treatment, but you don't feel happy, you want the patient katakan 2 weeks, then it's not a problem. But for me, my practice is only 1 month because I want to see. Okay, but if a patient have, I mean, always have sign and symptom, always feel free to call us. We see a patient soon, but if not, 1 month, I will do a clinical assessment. Rather, I mean, I don't take any radiograph because nothing much you can see when you come to 1 month. And after that, you just do regular check up 3 months and all. And depending on patient CRA as well.
Okay. Another question: how to cautiously remove the infected part without removing the healthy part? Can you recommend any best instrument to use?
Okay. Difficult question. Difficult question.
What do you use? Do you use burr or do you applique with the?
Okay, when it comes to this one, actually, I mean, this is from the textbook, the Annapurny, 2016. I have to put because it said that high speed burr will give a better option. But if you're not confident, then initially I use a slow speed burr. Okay, as you say, cautiously remove. Okay, but we come to coronal pulp. If you're certain, oh, okay, I want to do a coronal pulp treatment. So that you remove the pulp roof, you are gonna use a spoon like a excavator to remove the entire pulp. But become partial pulpotomy. If you ask me, I use a high speed burr, but I be careful on that because I mean, initially I use a low speed, okay, but when alhamdulillah I get the more a bit experience on that, so I use this high speed burr, but be careful when you do a cutting.
But I would imagine a high speed burr also give it a better, cleaner cut.
Yes.
But I think it comes back to the control. Okay, I think the last two questions. Zarida is asking which one is preferred for the caries, either complete removal, which may need pulpo, or would you rather go for stepwise? So that is making a decision between stepwise and complete removal of the
This one for
caries.
This one
Deep caries management.
deep caries management. Okay. Again, you have to go to your proper diagnosis. You see what is the clinical presentations of the patient, and also the stepwise is a bit okay. One, if a patient is a very, uncompetitive patient, you can't get a good isolation control. To be honest, yes, I certain patient I do a stepwise because I don't want that the tooth, the proper exposure. But this one, you must remember, is asymptomatic tooth. Okay, wherever patient come to you with the symptom, okay, this one, I think you can do stepwise. But for me, if patient can apa nama tu accept LA, you can put a rubber time. I will go for the either we'll see over the assessment, either direct pulp capping or partial pulpotomy, or if you go with coronal pulpotomy, because as you compare direct pulp treatment or IPT, the successful for the partial pulpotomy is better. The success rate is better, but again, I can't say that I will prefer one with another. It will depends on what is the clinical presentation of patients.
Okay, one last question for you from Dr. Farah. So this is like contradictory because you're saying that look at the radiograph, look at the history, look at the EVT, thermal test as well. So now, if you get some contradictory, that means you find that there's a TA lesion, but I also know that you said just now be very careful whether it's a real TA lesion or whether it's incomplete root formation. You get radiology as well. So if you get a radiology but EPT and cold test is positive, and there's no discoloration, what would you do then?
I wait and see. Wait and see, but you must do something as well. Meaning, because there is a paper, okay, scientific paper, even in close effect with periapical lesion, when you do the pulpotomy, okay, they have shown that the tooth is survived. There is no evidence of swelling and all, okay, and the good part is that you see the improvement or disappearing of the PA lesions, So based on this concept, okay, so you can still give it a yes. Always my approach, if I don't have at least 3 silent symptoms that make me really feel that, okay, these tooth you have to go for root canal treatment, then I won't do. I always wait and see, but I will make sure that I do, for example, do a clean up, put the dressing, a pub capping material, then I'm gonna put a normally is composite restoration. I don't put the stainless steel crown, but I don't go for GIC as well, because GIC, I mean, as you know, as compared GIC and uh, composite give you a better prognosis. So to answer your question, wait and see, but make sure that you do something on the tooth to protect the pulp, to ensure that you might be able to save the tooth.
Okay, actually, yeah, we do have a last one, shopping as well. So, shopping, this is very interesting. Shopping says the literature, from the literature, the bleeding time of 10 minutes is threshold to determine whether it's vital or non-vital pulp therapy. So this is by Lin et al. In 2019. What about the bleeding time for partial versus coronal pulpotomy? I don't, is there a particular time or more of a behavior of the
In term of hemostasis, actually, if a pulp tissue is healthy, actually you can get it in less than 5 minutes. Okay, but if you want to take that longer, then you can, but not more than 10 minutes. I think because it's definitely we show that there is some information going on. I hope I answer your questions.
Thank you so much. I think we've got so much of input as well from the participants. I think this is a really a very interesting topic, and it's a topic that we will continue to talk about. I think in time to come, and I think also at our conference next year, we will also be looking at the management of cases, which will also look at all these sort of parameters as well. Thank you so much, Dr. Shikin, for taking your time off to share with us. It's been really a good session. And thank you so much to all our participants and MAPD members who continue to support us. Okay, we will see you at the next webinar. And happy voting to everyone. Okay, travel safe, and we will see you soon. Thank you so much.